All right, so episode 1 on incentives, it was a barn burner of excitement.
Oh my God, I barely, have
It
recovered
was,
from that one.
yeah, I know. It was really,
It's
listen,
like a roller coaster of
I
delight.
a side note about roller coaster. I don't know if roller coaster sometimes is the best way to describe the ups and downs in lives. I mean, it technically is ups and downs, but I fucking love roller coasters.
Well, and I'm never going to go on one of those dumb-ass rides like the Tower of Terror at Disneyland where they just drop you
Why?
and then they bounce you because it makes me sick
Well,
and afraid for my own life. Even though I get that it's like a perfectly safe.
Is it really perfectly safe?
I don't know.
Stuff all the time from that.
So I'd rather be on a roller coaster than on something that just drops me and then jerks me up. That's mean. That's abusive.
Okay.
That's an abusive amusement park ride.
Okay. Well, you know what is abusive amusement park ride for me is those damn swings.
Oh, no, never going on those either. No.
The circle thing.
No.
So one of the things, I don't know if you know this about me, but like I love roller coasters. And this is why I don't think like, oh, it was such a roller coaster, because that's like a negative positive connotation. Lots of fun, not so lots of fun. I love roller coasters, so it's all fun for me. But so each year I go with one of my closest friends, Erica Powell, to Hershey Park. We are now going on year 3 that we're going to do it this year. We're planning for it right around Labor Day. And Hershey Park is as you would think it'd be. It's about like the chocolate Hershey. It's in Hershey, Pennsylvania.
Right.
And this is not a product endorsement, but I love Hershey Park. And here's the reason why I love Hershey Park. It's because it's small and and it's got lots of like really great, like 9 or 10 good hardcore roller coasters. And so you don't have to do all the crappy shit, like the teacups and the go in the circles. But last time.
Yeah, what happened?
And I'm almost going to wrap this up. But this last time, Erica says to me, she goes, Adam, look, I just really want to do the swings. I really want to do the swings. And so right at the end of the day, we were like, sure, we'll do the swings. I got off the swings walking kind of sideways and just wanted to lose my cookies. And I felt like for a solid 12 hours, I was in this vertiginous kind of state. Say no to swings. But roller coasters, yes.
You know what I really like? I like the Casey the Train roller coaster at Disneyland.
I've never been to Disneyland.
That's a you problem again.
Again, a you problem.
I'm really sorry. I'll take you.
Okay.
Okay.
Let's go.
Let's go. Let's go to Disneyland.
But I don't want to. I don't know. When I went to Disney World, my favorite ride out of the Magic Kingdom was the monorail back to the parking lot because I did not have a good time. Epcot was a little better.
I'm going to teach you how to do Disneyland.
Okay.
I'm the master.
And I don't like Universal Studios Hollywood. That is like being the last penny in a piggy bank, and that 3-year-old child shaking the piggy bank trying to get the penny out. I was that penny on those virtual rides. Also, not a good plan. Not a good plan. So, what were we talking about? Oh, healthcare is unstable.
Healthcare is a roller coaster, except you like roller coasters, so
that's not what we're
But
talking
one
about.
time we got off something at California Adventure Park at Disney. I think they've redone it. That coaster doesn't exist anymore.
Okay.
And some guy was puking his guts out.
Blech.
And my father, who we're going to have as a guest on one of our episodes, he thought that was the funniest thing he'd ever seen. I could barely get my dad off the ride. He was laughing so hard. Pointed at that guy. Look at that guy.
So I laugh on roller coaster when I get really excited. I get giggly.
Do you laugh when you see other people puking their guts out?
No, because I don't. I just.
Or do you not laugh publicly and you go home and kind of snicker?
Maybe I do in the corner of my brain.
Right?
I have like an
internal.
I know what we were talking about. This is the ADHD side of us. But the ER brain of us. We were saying that the last conversation around incentives was exciting. It was like a roller coaster.
Oh yeah.
And I was trying to say that all roller coasters or most roller coasters are lots of fun, and I don't get the negative side.
I'm not sure how we try to sell a conversation about the healthcare system and incentives if we're ever going to make people believe that. But
okay,
keep trying,
sure.
buddy.
Hey, we could try. But anyway, in this episode, we are going to continue the conversation that we had last time, and we'll get to more solutioning than moaning.
All right,
about
I like that.
About the instability of the U.S. healthcare system. And I think that's what we're going to do.
Well, that is what we generally say, what's unstable, and then what can we do to fix it?
Exactly.
Problem solution.
Problem solution.
Fits right in with our thesis.
100%. All right,
Okay,
let's talk about
go.
When it comes to healthcare and going back to our original conversation around what is health, is healthcare a right? how much of it should be fee for service, how much of it should be all profit driven, and how much should it be that incentive of come hell or high water, we're going to make a big profit. Now there is a no mission, no margin, no mission, but should we be in a system right now where every incentive is to do more? Because that doesn't necessarily mean what's best for the patient, not best for taxpayers, not what's best for kind of public health. Like, what would we need to do to start to shift it, to start to shift that kind of market in such a way to start to focus on outcomes of patients?
I don't have all the answers, but as you're talking, what's coming to mind is a conversation I once had with a plastic surgeon who said a good plastic surgeon should take abnormal back to the range of normal, right? We shouldn't have people walking around with deformities that we could help, or really debilitating, or you can't see, your eyelids are droopy. We shouldn't be taking people and making them into cat ladies or puffing up their lips with silicone unless you don't have lips, in which case puff away, right? Let's take people from abnormal to normal. Things beyond that, that's buyer beware, do what you want, people. I can't control it. There's that the book right now, Let Them. Well, let people do stupid stuff to their bodies. I don't want to pay for that.
Right.
But for a basic level, and I do think I'm a pediatrician, like vulnerable members of society might need a little extra TLC than people who are less vulnerable.
Correct. I mean, so we had a conversation on another episode where we talked about public health and socialism, and some would say that any focus on public health is some act of socialism, which is a scary word to throw around in the United States. But I'd like to reframe it a bit and to say that instead of like calling public health or focusing on preventive care through social policy, it's more of a commitment that we are making to make society a more healthy place, which becomes an economic engine for us.
That's right.
You can't have really great innovation in the future if you are squandering away or you're squashing the young population because they're diseased and not there. You have to have a certain social construct and commitment to making people healthy, because economies do better when people are all working together and not fighting over scraps, and more so they're pushing forward.
I think you just scratched the scab though off the biggest misalignment here, which is what's good for society isn't always good for isn't always what's good for me, the individual. And we're asking people in for-profit segments to sacrifice their personal, holiday to Hawaii for what might be societal good 25, 50 years from now.
And that's absolutely right. One thing that really strikes me here in Europe is there's a lot of focus on whether it's in France or Germany, Austria, here in the UK, there's so much focus on various social pieces to healthcare that we don't even think are necessarily healthcare, but they are. We've talked about this before about the public transportation system. So if you take it at its kind of heart, public transportation moves the public around a city, but that gives economic opportunity. That's number one. And we know that economics are certainly really help the ability for an area in a city to grow and for innovation to occur. But people have to walk more. People have to walk to public transportation. Yes, they get on a bus, but they have to walk to the bus stop because it doesn't go from their driveway or their flat or their apartment to wherever their point B is. They have to walk to those different places. That walking and that movement is critical to to increasing calorie utilization and increasing mobility and movement. I hear friends all the time like, oh, I went to Europe on holiday or on vacation and I lost weight, but I ate like all kinds of French pastries. And it's because you walked 11 pounds a day.
I moved to Europe and I did not lose. But I think what you've uncovered is innovation for convenience often leads to poor health outcomes, right? Like, I don't want to walk up and down the hill to my house, right? I'd rather have some little robot come pick me up or bring me my food or drop off the groceries. I don't want to have to go anywhere. And then I move my body less. Go to the grocery store. What's the most convenient thing to feed your kids? It also happens to be the cheapest thing to feed your kids. It's,
Right.
Takis or whatever turns my kid's mouth blue. Like
I don't know what
I
those
don't
are.
know. It's nasty. It's nasty. I can't even imagine what it does to their bowels.
Oh, I don't want to imagine that either.
No, because anything, just as a general pediatric rule, if your child eats something and they're stained blue at the end of it, it probably wasn't good for them,
Probably true.
right?
Agree. That would be a code blue instead of a code. That'd be a code blue. But so where I'm trying to, or what I'm trying to say is that, yeah, innovation is great. Incentives are there. A lot of the problems though that we have to that we want to fix in the healthcare system is because the incentives are to create profitability and not necessarily to create better health.
Right.
There are ways that you can say, change the incentives. So maybe the incentive is we pay you more for outcomes. Value-based care tries to do that. And there's issues with that, which we'll talk more about at a different time. But value-based care tries to do that. We'll pay you a block sum of money, and then you iterate, you innovate, you figure out how to take care of this population over this amount of time, meeting certain quality metrics. And then the incentive is what you keep or what you don't spend, you keep, like a savings account. You know, there are ways to incentivize social spending around campaigns, public health campaigns. I mean,
Even something as simple, have you ever read the book Nudge?
yeah,
Right? Even so something as simple as making the bananas easier to reach than the banana chocolate crap, that could like, yes, there's
I mean,
so many little things we could do just to push people in the right direction.
That's right. I mean, you know, a lot of times healthcare decisions are less about true decisions. They're more about convenience. And so making healthier things more convenient is a better way to kind of help health. But that doesn't necessarily mean those things are profitable or more profitable. And so shifting kind of what we desire as a country and what we believe is profitable or not. So like, you know, I've got a list here. I've got a list of like, okay, incentives for patients. I know, and I mean the list, but it's just the way I want to make sure we cover them. But like patients. So patients are, they have incentives of course, wanting to get healthy. But if they're on a high deductible plan, they may be insurance plan, their incentive may be, hey, let's wait and see. But then they may get too sick. And then.
Well, so the flip side is many people have advocated in the UK for the NHS for there to be a very small copay, because even a token copay, even if it was just like a couple pounds, would make people stop and think before they
Go to A&E or go to.
Yeah, exactly. And you certainly don't want to put an obstacle that's insurmountable in front of somebody who needs it. But I don't know the right answer there, but I know that's something that people talk about because I think there is evidence that even just a token amount that people would have to produce up front. But when you're now asking people to put something up that they can't literally afford, you're creating an obstacle. They're not seeking care.
Right. And at times we call that non-compliance, which I think is an awful thing, because when you look at the drivers of like, well, why did they not comply? Then you find all the different and things that are kind of pushing someone to not get to the doctor. They don't have a car, or the bus line is slow, or they are in where they are.
I heard our good friend Dr. Bio speaking recently about a patient she gave a prescription to. She raced to the pharmacy. They said, we're closing. We don't have it. You can come back tomorrow. She said, well, I don't have gas for the car. So she went back to the office. Bio tried to call her in a prescription to another pharmacy. They had the medication. She went there and said, oh, but the original pharmacy didn't transfer the medication. So now it's still sitting.
Yeah, but some doctors will look at that patient and be like, oh, she or he is non-compliant.
Right, 100%.
But when it's like,
you have to ask the next question, why?
Why?
We don't ask that enough in medicine.
So then we look at clinicians. So like we're hitting productivity quotas. Why? Because the more you do, the more you get paid, versus really driving meaningful care. And again, it goes back to the payment system.
You don't have time to ask why. You just walk in, shout some stuff at your patient, walk out.
Right. It's like we were talking about with Dr. Farmer and his cardiology patients, is that he is paid, or he is not personally paid, he's paid as a salary, but the system is paid in such a way that you have to see a certain number of patients in a certain amount of time, and they already have the disease, and you have to focus on the disease that is there, versus really stepping back and taking the time to understand what are all the drivers of this patient's health, because you don't get compensated for that the same way you do for doing the procedure or doing the critical care on the patient.
You know, people could hear that and think, oh, well, the doctor doesn't care. He's only going to do things he's compensated for. But that's not true, because you have external pressures saying if you don't see X number of patients in one day, you will not get your compensation at all.
Right.
Because you will be shown the door.
Shown the door. That's such a critical point, because it's not often the doctor's immediate like salary. It's not like when Laura comes to see me or I go to see Laura, I'm taking $10 or $15 or $100 and $150 from you.
Get your hand out of my pocketbook.
I know, right?
Right? Honestly.
But it's more so of that kind of driver we talked about before, of not wanting to be the worst doctor, or described as the worst doctor because you're the slowest, or because you actually spent time with the patient and talked with them. Then you've got hospitals. I mean, hospitals, like we talked about, are getting revenues from admissions. They're not getting revenues from necessarily preventing patients from coming in. Now, that's shifted a bit because of bundled payments and because of value-based care, but still the vast majority of the dollars that hospitals are making is by filling the beds, by getting patients in. Side note, I had a conversation with a hospital CEO once where I said, hey, we're going to participate with this program with ambulances to prevent ambulances from coming to the ER with patients that should not be coming to the ER because they're low risk or low acuity and could be seen at a primary care office. And they looked at me and they're like, do you still want a job here? Like, or do you still want to, that was not their exact words, but it's like, we make money off of patients coming to the ER and getting admitted, not by preventing them. So that's an incentive driver. Insurance gets money on the front end and they hope to not pay on the back end.
That's right.
And
that's the model of insurance around the world since the beginning of insurance.
Exactly. And they want to use that money for really what they want to use it on. And it's not necessarily to provide the care. Now, the Affordable Care Act tried to change a lot of those things. That's what I was referring to before about their profitability structure. But still, at its essence, it's keep what we get in the front door. Don't put anything out the back door. So these barriers of denials, these barriers of all, like you talked about.
I still have not had my knee surgery paid for. I posted.
When was that?
2021. And I even posted something on LinkedIn, and my friends at Cigna Global messaged me, please send us everything. 48 hours, they turned around and said, well, you didn't meet our criteria. I'm like, well, my PCL was ruptured and I couldn't walk. So I'm not sure what criteria I didn't meet, but thanks for nothing. Thank God I wasn't in the US, because I was able to afford the hospital bill and was really hoping to get some of that back. But here I sit, and now I think I missed my window, because if they push you long enough, then you're outside the window. Thanks, right?
Thanks.
I'm somebody who could afford to have my leg put back together. Right. So
and
yay
I've
for
talked
me.
to people around here that have done that too. Is that they'll use NHS, or they'll use, they'll pay for their MRI as a private, and then they'll go back and say like, okay, I've got a meniscus tear or something, and then they'll go to an NHS provider, so that they kind of hybridize that. But speaking of that, then there's the behavioral economics angle of like, what are the incentives for patients for their own health? Because there is a role that we all do play in our own health. At the end of the day, it's us in the box or us in the urn. Like it's not somebody else.
It took me a minute. I was like, my box of crackers,
no,
my
your
box of wine,
of the dirt party dead box.
Oh no,
it's
I'm all about the urn.
Us.
Yeah.
So it is incumbent upon us to understand health, to gain information. Rob has said this before on a previous podcast, and that is, we do have some responsibility, but from a policy standpoint and from a societal standpoint, I believe we have a responsibility of making health easier.
Right.
Because not everyone can be a cardiologist or a neurosurgeon or a neurologist.
Not everyone can afford a babysitter so they can go to an exercise class in the park.
Correct. So how can we make being healthy easier? Can we promote fruits and vegetables? Can we subsidize those so that it's easier to buy? Are there ways to do meal prep? And yes, that's going to be even more expensive, but we've made fast food easy, and it happens to be the worst for you. So are there ways for us to
but it's
promote?
delicious.
Well, sometimes, yes, that's right. Although I'm gonna say French fries, yes.
No, see, okay, I'm at a point in my life now where I eat that crap, I feel really bad on the other end.
Things. Yeah.
Like, I really don't feel good, so I like to feel good.
Yeah, so like I eat it and it's like, okay, so I'm in the UK right now. I had fish and chips because I have this like, piece of me that's
Yeah.
like,
I took
okay, I'm
my
in the
sister and
UK.
my nephew yesterday for some fish and chips, and I had
Well,
the steamed fish and some
no. I
peas, but they
had
had the proper fried haddock.
Oh, so I had proper fried haddock,
Uh-huh.
and and about midpoint, I was like, "This is flavorless fat, and it's not really good, and it's kind of gross, and I'm done." And I'm like, "Okay, I kind of don't want it anymore. I'm done."
But that's a hard thing because people are busy, they're rushing around, they're on their way to work, they're eating on the go. How many people actually sit down and eat
Right?
at a table, right? To even
Exactly.
recognize that I now feel sick. So, yes,
Correct.
there is personal responsibility, but I'm 100%. Where is the policy to make it easy and possible for people with less resources than you and I might have to make sure that they do those things?
Right. Well, this is the principle of nudge that you were talking about before. This is like make harder things easier so people
That's
are more
right.
likely to do it. And this also plays into the or the idea around public transportation, support programs for
Mhm.
maternal leave,
Yes.
support programs for paternal leave.
That's right.
Those
Just sidewalks.
or
There's
just
parts of America with
sidewalks.
no sidewalks.
Exactly. To be able to make it safe for you to be able to
Yes.
walk. So you're not like having to have a duel with
A big,
oncoming Big Mac,
yes.
So, and I'm not talking about
You don't, the hamburger, you mean a truck.
I'm a lorry or a truck.
A
A
lorry. Oh,
lorry. I'm in
good.
the
That's
UK.
nice.
So I'm
Okay, I
like,
like
yeah.
that.
I've actually had to use that with some of my UK friends. I'm like, do you know what a tractor trailer truck is? And they're like, I have no idea what you're talking about. And I'm like, a lorry? Oh, yeah, I know exactly what a lorry is. I was like, okay.
Those Brits are funny.
I know, they're so funny. We both married
We're both
one.
married to one.
I know, it's kind of
I
funny, right?
know.
But then, so how can we fix it? So, one, obviously, realigning those incentives, making sure that we're focused more on the outcomes and what is the end goal. Okay, so that's something that we talked about in my class, is that it's not any one group that's bad. It's that really policies do drive where we go. Another one is how we are paid. Like, should we all be fee for service all the time? Should we be leaning more into value-based care? And even in value-based care, are the timelines right?
Well,
Like,
back to the point of taking abnormal to normal, maybe the safety nets and the people that really support us to a certain level. And if you want something beyond that,
fine.
right.
Right, pay for it.
Yeah,
Like, that's
go for it.
okay. But should we not have some type of public system
Right.
in the US?
I'll
And
get you
some
an
people,
apple. It might not be a Granny Smith.
well, a Golden Delicious.
Yeah, but if you want to pick what kind of apple,
Is it Golden Delicious or Red Delicious?
well, there are two kinds of there's lots of apples out there.
I
There's so
just-
many
I
kinds
just
of
like
apples.
apples.
I'll just
I
get you
don't
the apple, and if you want to specify your apple type, that's up to you to make
Okay,
up the difference. That's
cool.
my solution.
Okay, I think it's a great one. But this reimagining the whole payment care model, we talk about, value-based care, but here's the problem. We have those systems, and then patients may be in it for a year or 2 years, and then they're out of the system again because they're in a new insurance plan.
That's
So
right.
we've got to really think through that incentive so that insurance companies are truly designing payment models for the longevity of their patients. That may take away some patient choice. That may require some congressional action, God forbid.
God forbid that the
But then there's
government.
behavioral nudges.
Yes.
So there's tech. My husband uses this thing, Duolingo.
I use Duolingo. It
Bing,
reminds me,
bing.
well, it reminds me almost every day that I have failed to do my Duolingo that day.
So he is on 357-day streak of his Spanish Duolingo. After we left Spain last year, at one
¿Cómo
point he was like,
estás?
"Yes, está bien." He said, "I'm going to start doing this." I mean, I learned Spanish in college. I was a Spanish minor, and like I do most of our translation when we go. And so he's like, "Okay, I'm going to do this." But that gamification, making it easy, he's sitting on the tube, or he's sitting on the airplane or something like that, and he's listening to it and doing it with his phone. Like, that's a way that we can leverage technology to like nudge people to do healthy things, tracking calories, giving people education. Those are really great things. And that's an innovative way to do it. And you can make money from it, but it's a win-win across the board. And then, I think there's this notion that you said it at the very beginning. When you came into my class, you're like, "Oh my God, I've got lots of letters behind my name and I know the healthcare system." And the fact was, even though you got an honors in class, you came in a little green.
I did.
Yeah.
I was like, oh, this will be an easy sleeper. And it was not.
I kicked your ass.
That's right. I had to prepare.
Yeah.
I had to read shit.
I know, right?
Doctors don't like to read shit.
No.
No.
But what we do need to do is, I think, have more doctors not just take my class, but more doctors have an
Every doctor should take
understanding.
your class,
Yes, thank you
Dr.
very
Adam.
much. But I do think they need to understand the business that they are
Yes.
in. We said at the beginning, $300,000 of debt when you leave medical school. $300,000. You would never say, I would never say to you, Laura, okay, I want you to invest in this company. It's called Lara Zibners and Associates. I want you to put $300,000 in this company. You know nothing about it, maybe a little piece of it, but you invest in that. And when you come out, you can invest in no one else. And now you have to pay for it for 30 years. Would you do that?
That seems like financial advisors say no.
Right. They would want you to understand the business, but yet we've done that as doctors. We've been
That's
very
right.
good at understanding our lane of traffic around patient care.
Well, because we grew up watching TV shows where we thought that it was all good.
Correct. But we didn't understand, we never understood the complexity of the environment, the pharma side, the payer side, the politics, and you hear how many people say, I want politics out of medicine? I mean, look at what's happening right now.
There are politics embedded in every kindergarten class. Like politics are everywhere. You cannot pull them out of anything, let alone healthcare.
Exactly. So having doctors, medical students have a more broad view so they can know how to advocate and be brought into the system to actually fix it. But that's going to take a shift in incentives as well. Medical schools have to be incentivized to do that. When they start seeing that doctors have to be at the table, they've got to bring the chairs to the table so they can be educated. And so I think, listen, if I had to design a healthcare system from scratch, I would not have a socialized system that would be completely socialistic. And I would also not have where everybody gets everything they want all the time and they have, all these panels making decisions for everybody. I would not do that.
No.
But I would also definitely not have the US system where it's a free-for-all. And we do ration care.
Yes.
It's based upon whether or not you have money.
That's right.
Not whether or not you really need it or not.
That's right. And that's the ugly truth that nobody wants to admit.
Correct. That is, when I remember back in the day, Sarah Palin talking about death panels, and things like that about Obamacare. I still have not yet. I've yet to see these death panels that have, even though Obamacare is now over 10 years old.
I'm sure that that's just a conspiracy to hide that from the public eye.
Probably.
Right.
Probably.
It's probably in that pizza parlor in Brooklyn. And that's where the
No, it was in D.C. It was Comet Pizza Parlor.
Oh,
it was in my neighborhood.
Okay,
so
that's probably where they're holding the death panel meetings.
It very well. No, we don't want our
we
pizza.
did not mean go to the pizza.
Do not go to our pizza parlor in D.C.
No, that was a joke.
But it was used as a way to scare people away from having any type of government policy, recognizing that the system we have now, that we like to call capitalistic, is not. No. It's guided by regulation. We're going to have a whole discussion around regulation. And
hold your pants on, people. Here comes the excitement.
That's excitement, but it is kind of exciting stuff. And then the flip side of that is that all healthcare, especially public health, has some level of societal good and commitment, which has like a little bit of a socialistic type of feel because we're paying into it for the good of other humans, not necessarily ourselves, which is not a bad thing.
It's not a bad thing. It's really not. And having lived outside the US for nearly 20 years, it's not what many people think it is. It's, I live a perfectly nice life with my capitalist ways, and, it's just about kindness and remembering we're humans and we need to look out for one another.
Exactly. So, okay. So last question then, and I think we'll wrap up.
I like truffles.
Boo. No. So what would be one incentive change, Dr. Laura, that you would make that you think would help make the system more stable?
Let's have medical school tuitions for people who are willing to go into the lower paying specialties.
Compensated.
You can't say at the beginning, you have to see it through, right? Mm-hmm. But if you go out, and we have some models of this, like the Indian reservation plans a lot of my friends did. But if we just said, look, go into pediatrics, internal medicine, and it's becoming more, there's broader numbers of primary care that don't pay as much, because if you don't do procedures, you don't get paid as a general rule. Right. So if you're a non-surgical specialty that just knows a lot but doesn't do stuff.
With their hands.
Right. I mean, you do stuff. But, the old joke, the surgeons do everything and know nothing, and the internal medicines know do nothing and know everything, and it's the pathologist who knows everything and does everything, and it's too late.
Right, by that time, because patients are dead.
Right. But I think let's start incentivizing people to go into the lower paying specialties. Let's take that burden off of them so they don't start their life deeply indebted, wanting to buy a house and start their family and not be able to do what they came there to do.
Exactly. I love that idea. Mine would be start to chip away at the financial incentives around our payment structure. I don't think we can move away completely from fee for service. It is so ingrained in the ethos, kind of in kind of the who we are in the U.S. healthcare system. But that said, we are incrementally making some changes, whether it's through Medicare Advantage, which is more of a value-based care kind of capitated system, or even through some of our Medicaid plans that are more of a capitated system. And even some of our insurance companies are starting to recognize there is a role to have more value-based care. So I think if we could accelerate that, like really accelerate that, and shift that financial incentive more to outcomes-based, less procedural and disease care based and more preventive care, I think that would make a lot of sense and would be really good for our population as a whole.
And buy more apples.
And buy more apples, make it easier to buy them, cheaper,
That's right. Put them on the shelf you can reach.
People in Washington would be very happy with us saying that. But, well, listen, this was a little bit more.
This hurt my head. This was really intense. Normally we just sit here and like shoot the shit and we think we're funny and we talk about shitting ourselves and patients shitting themselves, but this was kind of a
it was a kind of a necessary discussion because we've got to talk about
we got brains, not just humor.
I think so. Yeah. Maybe a little bit of both. I don't know.
Let's get a guest on next episode.
All right, I think we'll have a guest on next episode. So with that, hey, check us out on wherever you get your podcasts. It's really great to be on again with
Likewise,
you,
Adam.
Dr. Laura. And so until next time, healthcare is unstable and
so are we.
Thanks for tuning in to Unstable Vitals. If you enjoyed this episode, make sure to follow us for more unfiltered conversations on the pulse of healthcare. Connect with us on LinkedIn or visit unstablevitals.com to stay in the loop. And don't forget, real change starts with real talk. See you next time.